Hey, this week, join me, Dr. Robert Hacker, and Dr. Eleanor Stein. We're going to talk about something a little bit interesting. It's dysautonomia and compressive syndromes, POTS syndrome, Nutcracker syndrome, May-Thurner syndrome, connective tissue disease, pelvic congestion syndrome, something that really is under-focused on in the community, and I think that we can help.
Welcome to the Dr. Eleanor Stein podcast. In this show, you will hear expert medical professionals, researchers, and people with lived experience share science-based, low to no cost strategies to help people with complex chronic diseases. Listen in for another dose of education, empowerment, and hope.
Hi, everybody. I'm Dr. Ellie Stein, welcoming you to this episode of the Dr. Eleanor Stein podcast. Today, we're going to talk about a condition which you may not have heard of. I only recently became aware of it myself, and it's called vascular compression syndromes. It's a group of relatively rare conditions which just happen to be more common in people with complex chronic diseases, especially those with autonomic dysfunction. We're going to get a primer today from vascular surgeon Dr. Robert Hacker, and I will be learning right along with you. I'm going to be thinking back to patients I've worked with over the last 25 years and trying to understand whether maybe some of them suffered from this condition and I missed it because of lack of awareness. Dr. Hacker, vascular surgeons go to school for a really long time. So from what I can tell from his CV, he was in school for about 16 years before becoming a fully fledged vascular surgeon in 2014 at the University of Pittsburgh. He is board certified in both general and vascular surgery. And since graduating, he's worked in various roles, published papers, spoken widely around the world. And in 2023, he founded a new vascular surgical practice, and maybe he'll tell us a little bit about that, currently located in St. Louis, Missouri. He's won several awards, not only for excellence in surgery, but also excellence in patient care, being compassionate, even being on time. That one jumped out at me. What I value about Dr. Hacker, from what I've learned so far, is his curiosity. So I'm going to start by asking him how he became interested in vascular compression syndromes, because it's a condition that could give some answers to some people in our community that have really been suffering. So, Dr. Hacker, welcome to the podcast.
Well, thank you for the invitation, and thank you for the honor to speak to the audience.
You are so welcome. So when I looked up, you sent me your CV and I looked up some of your papers, and they were on pretty conventional vascular surgery topics like repairing femoral veins and arteries and stuff like that. But now you're really diving deep into venous compression syndromes. And I'm just curious, how did you kind of make the shift?
Yeah, so it's really interesting. Actually, it kind of goes back to the way the academic and training programs are focused. So
Mhm.
in America, at least, there's a big push for residents in any specialty to pay attention to patients who are being treated and write papers. And that usually creates what used to be a very traditional surgeon scientist pathway. In the vascular surgery community, there's a lot of emphasis. And I mean, I would say 80% or 90% of most people's interest falls into the arterial. And it's a very common misunderstood term in the population, but just to remind everyone, the arteries are the blood vessels that have the oxygenated blood, or technically are leaving the heart, if you want to be a purist, because the CT surgeons would say, what about the right ventricle pulmonary artery? So the vessels leaving the heart are the arteries. They are high pressure. There's a lot of them. The repairs are complicated, and they get the vast majority of the focus of trainees and programs, papers that are written. And veins have, even by me, are perceived as a lesser system. Once I had pivoted and left the academic pathway and started my own business, well, in private practice, you're going to see not the emergencies anymore. which are the artery stuff, you're seeing the more bread and butter daily people walking, talkies, coming into your office needing a vascular consultation. And there was a huge emphasis from veins. It went from 10% of my practice to 60% of my practice, 70% the first year.
Yeah.
And then, of course, when you see that type of volume, you start seeing patterns and conditions that you had never been exposed to before. And that kind of got us started on the whole compression pathway initially.
That's so interesting. And I'm sure it's true in other areas of medicine that academic medicine is doing the things that are kind of sexy or high profile. Like if you burst an artery, you're in big trouble. And I think you need emergency surgery right away, right? To even have
Yeah,
a chance to survive.
yeah, exactly.
So it's very high profile and, emergent and acute. But then when you move to everyday practice with kind of regular people, they're more interested in their veins. So what would be some of the, just kind of to give people a bit of a background, what are some examples of venous problems that people come in with?
Well, we do both, but on the venous side, the big venous stuff are painful legs, achy legs, varicose veins, a lot of pregnant women with varicose veins, a lot of postpartum women with varicose veins, workers, men with varicose veins, veins that bleed. Um, these lead to inflammation pathways where people might get skin discoloration of their legs. I think if you were to go and look at other individuals, you would say, hey, I think I know someone who's got a brown discoloration of their leg or a wound on their leg, right? These are the venous ulcers, bleeding of varicose veins. You see this whole onslaught. And what we realized is if you really sit down and dig into it, there's a whole group of women, not really men, who may have POTS syndrome. They may have left leg heaviness, not the right leg. They may have pelvic congestion syndrome, which is also very under-publicized in the female community, very poorly understood in the OBGYN community. And we're really starting to see that all these things are linked together, and I think grossly misunderstood. And then, of course, we have all the basic arterial stuff.
Yeah. Okay. So can you just kind of name the main compression syndromes that you see and how you would spot them? Like what would a patient come in complaining of that would kind of be a red flag for you that maybe compression is part of the problem? But maybe start by saying what it is exactly.
Sure. So when you flip open an anatomy book, you have to recognize we have two legs, but we have one heart. So we have one tube coming down from the heart, and then it splits. And then we have two legs and one venous return system. So we have two veins coming up, coming back together, and then going back to the heart on the other side of the spine. So this is the aorta and the inferior vena cava. Well, we're all anatomically built such that our arteries are on the outside of the legs and the veins are on the inside. And what this leads to is a natural kind of crossing over just below the belly button called the iliac bifurcation. And the iliac is just the medical name of what we call the new branched vessels after the aorta and the IVC. So this is 99% of the people are built this way. There's few people who are anatomically slightly different. And I would say in a vast majority of the patient population, nobody has a problem with this. But what we'll find is, I'm still unsure, and this is where some of our research is going, is do you grow into compression? Do you shift into compression? Were you always set up with compression if you have it and now you become symptomatic? It's unknown because there's not much data on it. The original papers go back to the 60s, a guy by the name of May and Dr. Thurner, and they had this syndrome called May-Thurner syndrome. And they noticed a compressive syndrome way back in the 60s where the right artery compresses the left vein. And this is known. If you ask most doctors, they're unaware of this, but it's known in the vascular community. But it was felt to only be a cause of significant left leg clots, right? So we've identified patients who, when you really sit and talk to them, they'll complain of left leg swelling. worse than the right when they're coming with their varicose veins, or they'll only have left leg varicose veins and no right leg varicose veins. We started noticing a big correlation between these compressive syndromes and patients with dysautonomia. Not just POTS, but I would say subclinical POTS. I believe the term POTS is very specific, but I think dysautonomia really triggers into a broader category of yet to be fully defined pathologies. So what we'll see is these compressive syndromes in the dysautonomia patients.
So if I can just jump in for a minute. So it's the vein is being compressed because the veins are kind of floppy, right? They don't have the rigid walls that arteries have. So it's like it would be hard to compress an artery, right? You would have to put a lot
Yeah.
of pressure on it.
So to give you an idea, if you were to take a piece of paper, I happen to have an envelope here. Here's an envelope. A vein is thinner than the edge of an envelope. It's
Wow.
very thin, very rigid, and it was meant to be a low pressure, high volume system. So it can take a ton of blood, but it's low pressure. So if you think in millimeters of mercury, so if I took a little thermometer and I stacked it up a millimeter of mercury, a vein is meant to be between 1 and 12 millimeters of mercury at rest. And an artery is your systolic blood pressure, 120/70. And so the arteries are very thick, they're very robust. And if you were to put the two next to each other in a competition, the artery wins every single time.
Okay. So the
And
compression is actually being caused by the artery compressing the vein.
correct. It's
Okay.
it's an anatomic closeness. And where we see the patients who don't have, which is most people who don't have it, there's just enough space in the way that the vein and the artery interact right in the pelvis that allows the vein to drop out, like running off the edge of a cliff. The vein just kind of sinks right down really quickly and isn't exposed to this compression. And in the patients that we see compression with, the splitting or the bifurcation is a little bit higher up and a little bit shifted over so that it can affect.
Got it.
Yeah, the actual sacrum or the bony prominence of the pelvis is actually creating the other side of the compression. So you have this soft structure between a bone below and an artery above, and then squished.
Got it.
We
you
also
mentioned
find nerve
May
there.
oh, sorry, you mentioned the May-Thurner as being one specific where the left iliac vein is being compressed. Yes, I got that right. Yes, I was
That always
paying
happens to me.
attention.
Yes.
And, what are some other types? Because there's, I think, 2 or 3 main ones that we
Correct.
talk about.
So the next compression that we've really identified, and it is very, very underappreciated, is something called Nutcracker phenomenon. And you say, okay, well, what is that? There's two types of nutcrackers in medicine. One is with your esophagus, which is very well known and understood. And the other one is the way that the kidney vein and the mesenteric artery interact. So if we go a little bit higher up in the abdomen, kind of by your xiphoid, where your breastbone is,
Yeah.
you have, yeah, very high up, you have two kidneys. So each of them need their own blood supply from the artery. Well, the left kidney is easy. The aorta's on the left, so it has a short little artery and it goes to the kidney. But coming back from the left side, it has to go in front of the aorta, and then it has to go into the IVC or the inferior vena cava, which is on the right side. It just so happens that when going over the aorta, there's another artery just before the renals called the superior mesenteric artery. And this artery feeds all of your intestines. And it has a lot of weight on it, and it can have several angles. So you have the aorta coming down, and you have the superior mesenteric artery coming off, and you have the vein going right through the middle. And some people just don't have enough fat in the corner, or they've grown into it, or they've raised it, or this angle is too tight, and that vein starts compressing and creates a back pressure. Now, this is, again, described in literature, but we've observed it to be very, very underappreciated for both its prevalence, how often we see it, and the severity of symptoms that it causes. And I think it's been because it's not sexy, and the repairs that have been offered are extreme. Kidney transplants and big abdominal incisions to disconnect the vein and re-sew it to another vein to help it drain. And so in the setting of that type of extreme scenario, I could see why doctors have been kind of like, oh, let's not mess with it unless you're really, really sick. And
And
so
so
it is.
you talked about for the May-Turner syndrome, the symptoms are really that there's a difference between the two legs because the blood coming back from the left leg is being impeded. And so the left leg is swelling, getting more varicosities, maybe painful. Maybe I don't know if there's more. And do they get pelvic congestion as well, or it's more the left leg with that one?
Yeah, so what we've actually found is the two syndromes are actually very intimately connected.
Okay.
We find that most people who have one have both more often than not. And unfortunately, I don't have enough data to give you statistical numbers. But what we find is that in both of these venous symptoms, the veins don't like having a lot of pressure in them. And so you can imagine when you're walking, your arteries are bringing the blood to your feet, and now you have to return it. So now it's coming back, and on your right leg, it's going up great, and on your left, it's not. And the human body has an amazing way of finding ways to get around problems. So what you often see is that these symptoms are in women, and you start to see uh, secondary blood vessels, which we call collaterals. Think of them like the side streets trying to get around a clogged freeway. And so you build all these collaterals, and a lot of them go into the pelvis. And this is where we see a lot of the pelvic congestion syndromes. We can see this May-Turner syndrome or a similar type syndrome being exacerbated by pregnancy from a heavy uterus being in the pelvis, tumors and masses. And once you've developed these collaterals, they usually don't go away. And so you start getting a lot of pelvic fullness and discomfort.
Mhm.
Um, and it'll often be very on and off. You'll notice when you're lying flat, there's no problems. When you raise your legs, there's no problems. But if you start performing exercise, walking activity, you may notice your leg gets heavy, discomfort, even more swollen. You can actually measure in some people an
Yeah.
actual size difference between the legs. And some people just don't know how to describe it, so they just call it a pain or a discomfort.
So again, like other I mean, we're going to hopefully bring these together a little bit, but like other autonomic dysfunction, it's worse when you're upright.
Yes, yes. And so we think that the way these are all connected is that from the groin to the ankle, the body very much relies on valves to keep the blood in place. And from the groin up to the heart, in what we call the box, essentially your abdominal cavity, there are no valves. So blood can go anywhere it wants to go if there's a pathway. And so we feel that, these compression syndromes are impeding your ability to return blood when you're standing. So your heart is essentially starved of blood. It's like not enough gas in the gas line. And when you're standing, you're also pooling it in the pelvis, which is also not helping it go back. So you're getting this double whammy.
And so, what would be more of the symptoms of pelvic congestion? Like a lot of women experience a sense of fullness. Maybe it's uterine, maybe it's ovarian, maybe there's fluid, maybe it's like bowel digestive issues. How would a person listening to this kind of clue in, like, huh, maybe I have pelvic congestion instead of maybe another label that they've been considering?
Sure. So again, you're speaking to a guy who has no idea
Right.
what it feels like to be a woman. But, having now interviewed hundreds of women, right? And having an intimate knowledge of what the internal organs are like from both a open surgical standpoint and a minimally invasive endovascular standpoint, I'm able to guess or ask questions that might drive us. So what I like to do is when we sit and we have an interview with the patient, I like to basically take the body and treat it like a banana. So I say, okay, let's peel away the layers and let's see if we can come up with a diagnosis or a question, right, that leads us to proving it or disproving it. So
Okay.
I just go back some basic things, right? So you know, is your pain related to your skin? Can you softly touch your skin? Does it cause a problem? And I literally go this slow. No, it's not a skin issue. The next thing is the fat and then the muscle. Is it light pain and discomfort in the muscle? Can I pick a rectus muscle and reproduce the pain or not? So, barring that, they say no. And then now that gets us to the internals. Now, the often biggest complaint that women will complain of is you say a heaviness and a fullness. So the first thing I ask is this cycle related? Or we have a lot of postmenopausal women. Do you remember when you were having your menstrual periods? Did it follow a pattern or did you always have it? Do you have pain using feminine hygiene products internally or being with a partner? Right? Many women who have advanced pelvic congestion will have such painful intercourse, which we call dyspareunia, that they won't have relations with their partners, and it creates a whole nother dynamic in the family. Many women have been complaining of this. Did we notice a pattern when you were pregnant? Not everyone has been pregnant, but many people have. And did it only happen during pregnancy? Did it get worse during pregnancy? Women who are multiparous, or those who have had multiple children, they'll often say, yeah, I was okay maybe at my first child, my second, I started having problems, and my third, it got worse, right?
Okay.
Have you had or even been considering a hysterectomy, or have you had heavy bleeding? There are many causes for heavy menstrual periods, such as fibroids, tumors, cancer. But we think that one of the bigger reasons may actually be this pelvic congestion syndrome, because the body wasn't meant to have such high venous pressure. And it gets misrecognized, and people end up having hysterectomies in the absence of other explanations.
Wow.
Do your symptoms get better when you lie flat? Because when you lie flat, lying flat is a great equalizer for pressure. Any pressure you have is now equal with your heart. So they'll say, oh, yeah, some women will say they actually feel the blood rushing out of their pelvis. And so what I encourage people to do who are like, is this something that's bothering me? Is you kind of just have to sit down and go through my little banana, peel away each layer and say, could this be my intestines? Okay, I ate something really bad yesterday and oh yeah, it's a grumbly stomach. Or no, I always have this irregardless of what I eat or what I do.
And would it be the person who has it regardless that is more likely to have this?
Yes, yes. In
Okay.
the absence of the other, like, let's say dysautonomia patients,
Yeah.
in your other women who just have pelvic congestion syndrome, yeah, they're going to have that fullness, discomfort, and achiness. Um, and again, some of them even had hysterectomies and still haven't had their symptoms go away. These are the women who we usually find have pelvic congestion syndrome.
And does it affect bowel or bladder function?
It can. So we've identified, you have to understand inside the pelvis, it's a very small space, maybe no bigger than a fist. And you have a uterus, you have a rectum, you have a bladder. All these things are very in a tight area, and you have all these varicose veins. And so what we've identified is some of these varicose veins become irritating to these organs, and they may cause a sense of like urinary urgency. We've had many women who come in with a diagnosis of cystitis or chronic cystitis, and they're on antibiotics, they're doing all the things, but they've never really had a positive biopsy that shows bacteria. And yet they still have this sense of urgency. And it's different than those who have the incontinence, the stress incontinence, like after birth, or,
Mhm.
women can get weak pelvic floors. Um, Many of these women have gone to pelvic floor therapy, done the whole thing, and have not, quote unquote, gotten any better. And that's when you really start saying, maybe we're missing something.
Okay. And then the one that's, sorry, I can't remember the name, the one that's the, renal vein,
The Nutcracker.
the Nutcracker, how does that present?
So this one is a little bit more tricky. So in the average walkie-talkie, you wouldn't know they have it at all unless you knew you had it, and then you could ask them questions. We had a patient the other day. We were working up for May Thurner, and we've evolved our diagnostic protocol now to always check for it. And there it was. The Nutcracker was there. She had no symptoms. She had no pain. Until I asked her, do you occasionally get flank pain? And she's like, oh yeah, I get it now and then, but I just chalked it up to X, Y, and Z. So she's asymptomatic. So what is the Nutcracker again? It's the renal vein coming back across, and then the superior mesenteric artery smashing it against the aorta. 95% of the population is built this way. Some people have what we call a retro-aortic renal vein. And so I wouldn't say everybody, because people are very different. But everyone's built this way. And what we've identified is patients who have these compressive syndromes typically have a loss of fat. So the angle is much tighter. So the vein is higher up in the angle and the angle is lower. So if you were to do an ultrasound on them and actually do the geometry, you'll see that they all have an angle less than 18 degrees. The GLP-1s have unmasked some people as there's been a big boom in weight loss. We've identified that the fat pad that was once there is now gone, and people who are fine are getting worse. But again, what you have to understand is you have one vein we haven't talked about, and that's the ovarian vein. So our body is split into two sides, and so the left ovaries and testicles are actually fed by a vein called the ovarian vein or gonadal vein, and they help to bring blood from the gonads up to the kidney and then to the heart. Well, a tube that goes one way can go another. And so what we've identified is patients actually have probably compensated for their compression by having the valve. There's what I call it a sentry valve. It's right where the gonadal vein and the renal vein connect. And we see this valve going away, which allows the blood flow to reverse down through the gonadal vein into the pelvis. At which point, many of these women would be fine, but most of them have May-Thurner syndrome. So from the pelvis, it tries to get back into the iliac system and then hits a second compression. So what you have is the left side of your body, your left kidney, your left leg, is actually sequestered, in a word, from your right side. So you'll get left flank pain, left heaviness. You may notice left fullness. And those are the patients who are what we call double compressors. They have the most amount of symptoms and compression.
How common are these conditions? Like, I have to be honest, before I heard you speak recently, I really had never heard of them. Granted, I'm a psychiatrist, but I've been working in this community for like 25 years.
Yeah.
So that's why I was so excited that you were willing to share what you've learned.
Absolutely. Again, without the research papers, right?
Yeah.
Um, I would say just from my days in academics doing a lot of arterial work, I may have done 5 May-Thurner cases in 9 years of practice,
Okay.
right? We do 5 to 10 a week now in the office. And so when you look at the normal population, these are rare, let's just say sub 7% of the population. But very specifically in the dysautonomia patients, we've identified, I would comfortably say greater than 95% of the patients have these compression syndromes.
Wow.
Which leads to an entire another conversation is how is dysautonomia and the compressive syndromes related to one another?
Excellent. And?
So one would say, I don't know, but the hypothesis is well, I'll go back a little bit. I'll go back to how we found it and
Okay.
lead to our pathway.
Yeah.
So we start the practice. We start seeing a ton of vein patients. Some of them have the May-Thurner. We know it because it's in the literature. So of course we use our ultrasounds. We look at it. We see the pattern and we treat these patients. And they come back and they say, thanks for treating my leg, doctor. Thanks for doing my varicose veins. And oh, by the way, I happen to have POT syndrome. I just didn't really mention it because none of my doctors ever listened to me and I didn't want to ruin my exam. We know the story. If you have it, you know the story. And I got better. This happened once.
Oh, and the POTS got better when you treated the May-Thurner.
Yes, yes.
Oh.
So this happened 3, 4, 7 times. And I said, there's got to be something here. And so that was about the time that we recognized we should start taking care and watching our data. So earlier in 2025, we started really chugging the data from the practice. And that's when we came up with the initial hypothesis and presented it at the Dysautonomia conference of 2025. And what we identified was that we use statistics in research to really validate what we're doing. We found a statistically significant result, and that patients who took a validated test called the Malmo POT score and who took the pelvic congestion syndrome test all had improvement in their systems with a p-value of 0.001.
Wow.
We consider anything statistically significant better than 0.05. So, I mean, this is the best you can get. And so we identified we're not making their POTS symptoms go away, although we do have many people who say their symptoms are gone. This is not what we lead with. We say that they have a statistically significant improvement in the quality of their life. So,
Do you think it could be something to do with connective tissue laxity? Like many people in our complex chronic disease community have connective tissue, we'll just say disorders of various types. And I've always thought, rightly or wrongly, they're more likely to get autonomic dysfunction because they just don't have the rigidity to be pushing the blood around effectively. And I wonder if veins that are a little bit more floppy are more likely to get squished.
I think that was a kind of my initial hypothesis. I actually think in a few more years, we're going to find that this is all related to neurons and the brain and the peripheral nerves, which is why I love the term dysautonomia because it doesn't put anything in one specific box, but I think it really classifies the whole group more eloquently. Um, to the connective tissue point, my initial hypothesis was, oh, people have connective tissue disease, they're going to have worse disease. That's evolved a little bit. What we've identified is that we have many people who have both connective tissue disease and don't have connective tissue disease, but they have dysautonomia. The
Okay.
ones with the connective tissue disease, though, we've identified usually have worse varicose veins, as you stated astutely. The veins can stretch, but if they get beyond a certain point, which is going to be a lower threshold than the average person, they stay stretched. So the varicose veins stay longer, the veins are bigger and more robust, which leads to more potential space for capacitation of fluid
Yeah.
and worsening symptoms when you stand up. And so the answer is yes and no, because the compression
Okay.
is there regardless.
So can you just say a little bit about the neural hypothesis? That's new to me. Um
Sure.
how is that connected?
Sure. So, this initially kind of got started with the observation of fibromyalgia. So in surgery, we make incisions on a lot of people. We do some major operations, right? Not everything I do is minimally invasively.
Yeah.
So we had a whole subset of fibromyalgia, and I recognize fibromyalgia patients are unable to um, like mentally tolerate even small movements, blowing of wind, touch people lightly touching them. And to me, it's a filter problem of the brain because we're being inundated with information all the time. And it's the brain's job to kind of filter these things out. And so, without me quoting papers, my feeling as a surgeon is the fibromyalgia patients, their brain is unable to filter out some of the lower innocuous lesions or
Right.
input, and so they're bothered or disturbed by even low level things. And so big things really, really disturb them. So if you take that and you say, okay, what's happening on with these dysautonomia people? We recognize that a lot of them have vagus nerve symptoms. A lot of them are either rest or relax or fight or flight all the time. They're primed. And so the hypothesis is that once the vagus nerve, which has two branches through the neck, where we see it all the time for carotid surgery. It's about the size of a linguine, and we move it to the side. We do our carotid repairs. It continues into the chest. Once it hits the stomach, it rotates 90 degrees, and then it kind of like spider webs itself in the abdomen amongst all the organs. And so its interaction on the celiac, we believe, leads to the mouth, the median arcuate ligament syndrome. In the Nutcracker, you see a very robust network around the nutcrackers because it's traveling through into the intestines where it's going to have a lot of influence. Pardon me. And so this is when we were talking with professionals like Dr. Kinsella and Dr. Lenny Weinstock about the MCAS patients. This is when we started putting all these theories together because if you have a compression and you have these fibers, and they're interacting and they're being compressed, what's to say these fibers aren't being prematurely activated every time the heart beats,
Wow.
leading to vagus nerve stimulation, leading to a lot of the symptoms that people have. They're constantly trying to rest and relax, you know, distension, bloating, and then their body has to get up and they have to be in a sympathetic tone because the body's all about balancing of tone.
Yeah.
And they can't do it because essentially they have a pressure point on their vagus nerve. And then if you add the May Thurner, there's a large network of nerves in this same location. And we know they're parasympathetic nerves because from doing our open aorta surgery, we know the sympathetic plexus is actually on the other iliac artery on the right. And it's a very defined nerve bundle. And in young men, we have to avoid it so they don't have something called retrograde ejaculation. So if we take our surgery knowledge of, we know where these nerve bundles are from doing open surgery, and then we kind of listen to patient stories and we overlay a little bit of creativity, you can start to see, oh, maybe this pattern is in fact the case. Because how many people here are listening to this podcast and you say, hey, listen, okay, do you have abdominal pain? Do you have bloating? Do you have distension? When we start, do you get pelvic pain? Do you get left leg fullness? When you start talking to vast majority of women, 97% are women in our clinic, 80% of the stories have all the same core. And then every person has their own, I would say, individual flair, if you will. Some get better with this and some don't get better with this. But for the most part, they're all the same. And a lot of them are vagus nerve associated, and a lot of them are heart rate associated.
And you've mentioned a couple times, and thanks for just giving those like kind of alarming stats that it's 97% women. Why do you think that is?
I have no idea.
Wow. So you do see occasional male patients, but
In our
very rare.
clinic, yeah, I mean, in our clinic, we've treated, I think as of last week, we're close to 175 vein stents have been placed. So we've
Mhm.
seen several hundred people. There's 6 gentlemen, maybe 5. That's it. It's all women, almost all the time.
Wow. I mean, it sounds like there's a big hint there for someone who happens upon, what the reason might be.
Yeah.
And what are some of the triggers? Like, people aren't coming to you at birth. They're coming, like you said, a lot of people older, postmenopausal. Um, do you have and do they come with a trigger like I was okay until this happened, or I got long
Yeah,
COVID or
yeah,
something like
yeah, it's
that?
interesting. So in the dysautonomia community, you'll see several big triggers. Vaccines were one of them. COVID was one of them. Illness is one of them. Uh, Traumatic brain injury has been one of
Mhm.
them, right? But in all of these, you see the common thread. It's nerve related. If you really listen, right, somehow the nervous system has been involved. For us, the triggers are various. I mean, we'll get full families. I've gotten a grandmother who came in with the mom, and the mom's in her 30s or their 40s, and they talk and they're like, "Oh, we've had that." And we do an ultrasound and they both have it. And then the mom says, "Oh, I need you to see my daughter or my son. We had this the other day and they have it." And so again, I think there's some kind of familial inherited pattern. One wants to go back to the connective tissue, say, is this part of it? Unsure. Or is it just random how you're born and it just happens that way? It totally unsure at this point, but there is something that is consistently occurring, and I think one day we'll get to the root of it.
Very fascinating. If someone suspects that they have, like, how do people get to you? Because they must already have a suspicion. Like,
Yes.
you're coming, you're starting to get your name out there as someone who understands these conditions. So,
Yeah.
how do people kind of figure out that you might be someone who could help them?
This has probably been the hardest point right now because we recognize that there's a lot of people. If you take what we've seen and you extrapolate it, I've heard numbers as high as, there's 40 or 60,000 people out in the United States who are suffering from dysautonomia of one way or another, right? Just huge numbers.
Yeah.
Um, it's been very hard because there's so much noise on social media. There's all these. I am not very facile with Instagram. I have like 7 posts. If you were to go to our Instagram page, the STL Vascular Instagram page, you'll see an angiogram with the reflux and everything. But we've been trying to be more grassroots. Also, you don't see me jumping on the roof, banging a bell, saying "Come to us," because
Right.
we believe in the practice. We want to be very tempered and metered because we have this data, and I'm always trying to disprove that I'm wrong, because
Right.
we have a responsibility as doctors and surgeons not to go down the wrong pathway. And so we're letting the data and the results drive us, and we have a big grassroots and word of mouth campaign. People are finding us on the internet, maybe through a podcast like this.
Hmm.
But it's getting to the point where I'm becoming more and more confident that we're doing something that's special. And, we would like to find a way to connect with more patients because the stories, the life improvement stories are just phenomenal.
So maybe walk us through what evaluation you do if people do get to you, and then if you find one of these syndromes, how you manage it.
Yeah, absolutely. Before we go that, I'll add one more
Okay.
symptom we haven't talked about,
Oh.
which is headaches. There's a lot of
Oh.
people out there who say they have very bad headaches. They've had blood patches or spinal headaches. They're neurologists. And I want to put that out there because there's someone who's like, oh, I've got all this, but I also have headaches. And the headaches are from the Nutcracker phenomenon. The angiogram on the Instagram page shows a really good example of how the spine drains. So how do we go about stuff in the clinic?
Mhm.
Well, before it used to be, hey, I have some varicose veins and my left leg hurts. Now, literally coming with us and saying like, hey, I've seen 5, 7 doctors. My cardiologist, there's nothing wrong with me, or I have POTS, or I almost have POTS, not quite. My neurologist, says there's nothing wrong with me. My EEG is good. My EMG is good. My nerve conduction study is good, right? We'll get people from, Dr. Weinstock because he's in town in St. Louis with us, and they'll say, I have MCAS, the mast cell activation
Mm.
syndrome, which is a whole little thing we can spin off in a minute. Um, they'll say I have these crushing headaches that won't go away, or they only go away when I, lie flat. I have the connective tissue disease. They come in already having seen everybody and exhausted everything, and they're on an oral regimen, usually of like salt, rest. Some people are on disability.
Yeah.
And now the workup's pretty streamlined. So basically, we'll sit and we'll have an interview, talk really quickly, and I really try to rule out what it's not. Right? I'll go through the whole banana analogy of, okay, you're having pelvic symptoms, is it this, this, and this? Some people have had, low grade abdominal discomfort. Yeah, I feel less likely, right? But you ask them, leg pain, leg discomfort, varicose veins. Now, I've had people who are in the medical field even say I have groin pain and it'll be on the right. So I don't let the side drive it. They'll say they have low pelvic symptoms, right? Miscarriages, heavy bleeding, painful intercourse, history of hysterectomy, just a fullness, achiness in the pelvis. These are all, to me, warning signs, right? Urinary urgency. As I'm moving up, to the Nutcracker, bloating, left flank pain, in the extremes, urine blood that may be microscopic but might come up on a test and there's no explanation, no infection, right? And headaches. So if you fall into this, you're giving me the story, you say, okay, you might have it. So what do we do next? Well, there's kind of this principle in the surgery world, go least invasive to most invasive. Most medical doctors will practice this because, again, you have to remember everything you do has a risk. So let's not take unneeded risk. So I have an excellent team of ultrasound technicians in the office, and we have the best equipment you can get. Someone probably got something better, so I'll say the next best equipment in the office. But if you walked into our office, you'd be like, wow, this is really good technology. And we've come up with a protocol for screening. We came in with our protocol and found out that another society for ultrasound had actually made a similar screening. And so we independently came up with it. So we know it's a good protocol. And we use a simple ultrasound, which most women aren't familiar with. And we look at the flow pattern at the groin and at the belly button of the veins on the left and on the right. And then we try to look at the nutcracker. Sometimes people's body shape won't let us, or they ate, or there's gas. But we try to do a screening test with an ultrasound. And what's interesting, since we do a lot of varicose veins, if you took all of our vein patients and you screened them, 5 to 7% have these compressive syndromes.
Wow.
So we're,
But didn't know it. They just thought they had varicose veins.
yeah, they do. So 95% of the time, you just have varicose veins, and we'll
Yeah.
do that. But in the POTS or dysautonomia patients, 97% of the time, it's there every single time. Like, so much to the point that the techs do everything without me, and they're like, they've got it before I've even seen them. Sometimes, we value patients' time. We really try to make sure our office appointments are efficient, and we try to spend as much time with patients, and we'll flip the order sometimes, and they'll go ahead and screen them based on their little screening
Yeah.
questions. And there it is. So now we have a good story. We have a non-invasive test. And so what's the next thing that you do, right?
Yeah.
Well, if you're a 13-year-old girl, which we had the other day, we don't go any further. But do you know what we just told that 13-year-old girl and her mother? We think we have a good explanation why you feel this way. Let's see you in 6 months. Let's see you in a year. Let's keep you going. Let's keep you motivated, and you're not crazy, right?
Right. So validation is huge.
Huge, because we've named the thing that's been causing them discomfort. And we might do the same thing for a 16-year-old. We might do the same thing for an 18-year-old. Where we pivot is quality of life. I have some young women who are looking to fail out of school.
Right.
They're not doing well in college. They're not doing well in their job. They're on disability. To me, in the risk benefit category, the best thing you could do would be to get them back on track for life. I mean, just think about the long-term consequences of someone not being able to go to college, and just how their whole life path changes. Or they're in a relationship and the relationship's rocky because they're sick all the time, and you could correct that train, right? Or they want to have children and they can't because this syndrome is preventing them from doing it. So in the young population, we try to be very cognizant of what we're doing, because these stents can't come out, and why we're doing it. But before we go there, we go another step. So before we treat it, the next thing is what we do is a diagnostic venogram. So we talk to you, we do the ultrasound, and then we schedule a diagnostic venogram, meaning you come to our office, you lie on the operating room table, we give you some relaxation medicine. You can still talk and breathe. And we put 2 little IVs in your veins in the groin, and we take pictures with IV dye.
Right.
And then
So
we
you
take
can
them.
totally see it. Like, I've
Yeah.
seen some of your images. It's just, yeah.
Yeah. And like I said, on the Instagram, you can see a venogram of a patient. And then we use an intravascular or inside the blood vessel ultrasound machine. So not only do we take a picture with the contrast, we actually measure it through calipers. And I think that right there was the critical evolution in our workup, because when I used to just interpret the venograms, so many times I said, you don't have it, because we actually didn't know what we were looking at, because the body's compensated so well. Put the ultrasound in, and there it is, like 90% of the time. And sometimes we can even reproduce the symptoms on the table that the patient's been having, to basically confirm that these are the things that have been bothering them.
And when you say that the like the intravessel ultrasound, what you're looking for constriction?
Correct.
So
So
you're okay.
yeah, so we can see the diameter of the vein, and you'll see it just boop, go down to nothing and then come back. And you'll see where the artery is on top beating it,
Oh
or
yeah,
you
yeah.
see on the Nutcracker where the compression is, and you can see the little angle. All these things that I'm
Yeah.
showing you are things that we see, and we see the same pattern over and over and over again. So now,
Yeah.
rather than just guessing what you have, I can put a little tiny tube in, take a picture, and I can see your renal vein refluxing. We can see the blood flow around your spine that's probably causing your headaches. We can see the pelvic filling with blood vessels. We can see the compression. Like, we can really prove it. And that's been the big change for me, is now that we have real data, real scientific data, do you treat it? And then the patients that we treat, they get better.
And so maybe talk about the treatment. You said it's a stent, so
Sure.
that's like kind of a rigid tube that you put in to support the vein so that it doesn't get squished?
Sure. So again, I mean, you're a surgeon, you only have so many tools. So what are you going to do? You're not going to remove the vein. If you balloon the vein, which is a very temporary fix, you can set up an inflammation pathway, but all the balloon is going to do is spring it out and it's going to spring right back. So by the time we're done with that case, you're back. So the balloon isn't going to do anything. So the standard treatment for Maytherner has been a stent. And again, usually Maytherner was treated for like DVTs in the leg because the compression was so bad. But we realized that it can help open up that compression, drain the pelvis, get that blood flowing better, get that leg flowing better, give your body access to the blood for the patients with dysautonomia, right? Because there's a lot of blood down there. And then there's a whole sequence. Sometimes we put the stent in and we will do pelvic coils and embolizations at the same setting where we'll put little tiny, think of them like springs or chemicals to get rid of those varicose veins. Sometimes we'll do that at another date, but that's how we treat the pelvis. And then again, trying to always do as little as possible. Sometimes that's all a patient needs. And you'll say, well, why does it work? And this is where the research is. I don't know why it works. There must be something about the nerve plexus again on the vein and on the artery, but by opening that space, a lot of patients say that their POT symptoms improve. So is the artery compressing a plexus near the vein? Is the artery just giving it space, allowing it to beat without any interaction? That's an area of research, and I think it would take some really eloquent studies with like vagus nerve to figure it out. But it works. And the worst patients have the worst pain. It can be quite uncomfortable with a low pregnancy labor type pain because that's the nerves that are getting irritated between 2 and 2 weeks. Some other lessons we've learned is I'm sure people out there have either been stented or talking to get stented by other specialties. We've learned that not to oversize these stents. Uh, please don't do that. That's where a lot of the pain.
Bigger isn't always better.
It's not, but that's what's taught in the academics, and we're really trying to flip the script. There's this big concern about movement of the stent or migration.
Right.
Remember, it's being deployed in a compressed scenario, so it isn't going anywhere. We've also identified how we've been doing it. We're doing these stents differently than most centers. We have a large academic center in town. They do a very traditional way. We bring ours all the way up into the inferior vena cava, which really lifts the aorta off the blood vessels, treats both the right and the left leg. And the data there is so compelling. It's being presented hopefully in 2026. I've just submitted the data for the paper of like 146 patients for this with no complications.
And can you talk about the stents? I know you wanted to talk a little bit about MCAS, and I don't know if this is a segue, but there's worries that the stents may not be compatible or they may trigger mast cell activation symptoms.
Sure. Well, I think for the mast cell component, you have to understand, is it a chicken or an egg argument? And I make the argument that mast cell is an egg, meaning you had a chicken first. And so we believe that the patients with mast cell, from repeated bouts of inflammation and hypotension, their bodies essentially are freaking out. It's like you got shot in the pelvis and then they stopped it and you got shot again. Being surgeons, we've seen this, and this is how your body reacts. And it gets to the point where it starts just releasing a whole bunch of chemicals. Now, we also know that the collagen is different in some of these connective tissue patients. So we don't know, am I right? And it's just they have a lower threshold, or is there another pathway? But a lot of the hypersensitivity patients seem to be the result of prolonged, right? Most people don't get POTS and then MCAS immediately. There's usually a long drawn out period. So we've spoken to several dermatologists. We've asked them the metals that are used in these stents is something called nitinol. It's nickel titanium. It was invented by the Navy many, many years ago. It's in almost all medical products. And even if you have a nickel allergy, the functional component is so small that you really have no reaction. Also, a lot of immunologists and allergists will tell you that intravascular reaction is different than skin dermal reaction because the intravascular system doesn't have the same level of like histamine uh, sensitive cells like the skin does, where the skin is trying to protect you. So we are unaware of anybody having an allergic reaction
Wow.
from
So out
this.
of the, you said 100 and something stints
Yeah,
that you've put in, and nobody's had some weird
not that we've
inflammatory
been told.
response. Yeah, I'm sure they'd tell you.
Oh, oh, they'll tell you, right?
Yeah.
This is a very vocal and self-advocating group. Up for the Nutcracker, we believe that the Nutcracker um, should be treated a little bit differently. So we use one stent by a specific vendor. Uh, I won't promote vendors, but we use this stent for a very specific reason. It has an open cell. It has a high force, what we call radial force, and it lets us do the treatment in a segmented fashion and deploy it unlike previous generation of stent. Up in the Nutcracker, we treat it with an entirely different stent that's very big. It's a different type of approach, and it helps treat the reflux and gonadal and open up that angle. And we've noticed a lot of people with the GI symptoms improve after that. And that one I really feel that has to do with the vagus nerve component. There's a huge plexus there, and a lot of the patients improve. So we have many people who are double compressors. We treat them with the May Thurner first, the Nutcracker second, and all of them have said that they have improvement of their symptoms.
And this is all minimally invasive, like you're going in through the vein. You don't end up with a big scar.
Correct. So even in people who have connective tissue disorders, right, who are
Mm.
prone to scarring, you're talking about an incision no wider than the width of a nail, just
Wow.
as wide as a little knife to stab in, and it's all done with X-ray minimally invasively.
And what are some of the side effects of putting a stent in?
The biggest risks, we have to talk about are you gonna have any long-term benefit? So,
Mm.
unlike, amputating a leg where we know you have no leg when we're done, I don't know if you're gonna get better from this, and I'm very clear about this. I think everybody is individual and there's not enough data, but we put that out immediately. But we hope that we're doing it for the right reason, and this is why we go through all these steps. Another concern would be clotting of a vein. Depending on how you place the stent, do you have any underlying conditions? You could clot these stents off. Our Mayther stent, we have basically no incidence of thrombosis. There's one patient had some scar tissue, but it didn't clot. We
Mm.
just put her on some prophylactic or just in case medicine as a blood thinner for a month. And in the renal, we have had no reported clotting of anything, although it's a risk. Migration or movement. These are going into compressed scenarios, so the migration risk should be very, very little to none.
Okay.
And then long-term patency, right? These are inert metals, so they should have a long-term shelf life. The Nutcracker is a covered stent that we use, but it's an inert material that the covering is placed with. And so the only potential long-term risk would be maybe some inflammation in the vein itself. Now,
And so could these stents stay in, like, say you have a 20-year-old, th I guess we probably don't have enough data to know for how long might this stent be effective, or, is it
it'd
like
be
a
for life. That's how I
okay,
plan for it. Yeah.
okay,
Now, even though these stents aren't placed in this location and there's a lot of papers, there are arterial stents which have been placed and manufactured by these companies that use the exact same principles. There's some engineering differences in them, but it's the same metal and it's the same fabric. They've been in patients for decades. And
okay,
so one could extrapolate, well, if it was good enough for an artery, it should be good enough for a vein. These are not
yeah.
new and exotic type materials. These are materials that have been tried and true for decades. I mean, there's patients who I trained on, you know, 20 years ago, we were using this technology. So we know it
Okay,
has
that's
staying power. Yeah.
yeah, that's reassuring that it's not fancy and new, it stood the test of time.
Yes, absolutely. To the best of our research ability.
What about non-surgical interventions? Say it is a 13-year-old, someone who's planning, I don't know, for some reason can't access, maybe financial reasons even, the surgery, are there strategies that people could use to kind of help them manage?
What's going on? I
Yeah.
think the first and foremost is fear. So when you have something and you don't know what it is, and it
Yeah.
makes you feel terrible, it probably makes it worse.
Right.
So our ability to, even if you never saw me and you listened to this podcast and you said, "Hey, this checks 9 out of my 10 life boxes," right? Let's just pretend I have it, and I can't afford to go see Dr. Hacker
Yeah.
or or I'm gonna take this podcast to my doctor, but they're unwilling to do the test, right? So I'm
Right.
gonna pretend I have it. I think just knowing that, this has clearly been around for millions of years,
Mhm.
right? This is not a new thing. We're just now being able to treat it. So we know people have had it, people will continue to have it, and you'll get through life. You're
Right.
going to be
It's
fine.
not a fatal progressive condition. You'll have discomfort,
Yeah.
but you can live your life.
Yes. And one of the bigger strategies I've been trying to work with is, there are monks who train in the Himalayas to to endure pain, right? You see the little parlor tricks on the so one then has to ask herself, okay, really then this higher level of pain is uncomfortable, but is it a permanent state? And now that I know what my problem is, or I know what I think my problem is, and I
Mhm.
know I'm not going to die from it, can I start training my brain to ignore it? And I think that's where cognitive behavioral therapy and other strategies may have a role in the populations that don't want to seek
Mhm.
surgical intervention, can't seek surgical intervention, are nervous about intervention, right?
Yeah.
Um,
That's really interesting because it's actually one of the things I've trained in and offer, through my online business is teaching people neuroplasticity-based strategies to basically turn down the sensitivity of the brain so that even if they have an ongoing biomedical situation sending nociceptive signals up to the brain, it's still possible to turn that down so you're not living in so much misery.
yeah, there are proven scientific methods.
Yeah.
If you can recognize what the problem is and you can name the problem, you can physiologically or through your own body's activity start reducing the volume of these things.
Mhm.
I think a lot of the fear cycle is there's a lot of anxiety in this patient population because there's a lot of unknown,
Yeah.
maybe other home factors, things that I can't really put my finger on that people are struggling with or suffering with, both financially, socially, right? But if you can give this kind of a name, I say name your monster, and you can
Yeah.
see it, you can suddenly control it, and you can take your life back, and you can know that there's a future, and you no longer have to be a slave to it, which is what we try to tell people. Our treatment doesn't get rid of it, or it does for some people,
Mhm.
and I don't know if that's a placebo effect or not. But those who say they're getting better, and they know that they've done everything that they can, and you see them improved, like, visit after visit, because 'cause we've been watching people closely, and I think there's something very powerful in, being able to take control of your own life and responsibility for it.
Yeah, that's fascinating. I didn't expect our interview to go in that direction. Maybe just a couple questions before we wind down. So, are there people like physios who can help, I don't know, recommend lifestyle strategies or massage, or I don't know, I'm thinking of like massage to get the fluid out of the lower body. Are there strategies like that?
Well, remember the fluid is it's not like lymphedema where you have this fluid kinda stuck in the layer of fat and you can't get it up. This is your venous blood, and it's just
Okay.
got a narrow valve. So you can get it back by raising your legs. You can
Yeah.
auto transfuse.
Okay.
If you're getting a headache, just lying down and raising your leg auto transfuses about a liter of blood into you immediately.
Wow.
So if you're like, "Oh, I don't feel great," just lying down and doing that. The other thing is I think not going down the cycle of, anxiety. You'll see this
Mhm.
too. Anxiety begets anxiety begets anxiety, knowing that you have strategies to reduce these things. Some of the pelvic pain and discomfort is cyclical. You can have it one day and not another. I have a patient who is just in the ER again for an exacerbation. Um, Being able to just recognize, oh, this is my thing, and I'm going to, I'm listening to my body, but I'm not freaking out.
Yeah.
Not having to get in that cycle of going to the ER. I think people who are trained in biofeedback, therapists and whatnot, training patients to again, work on biofeedback, could be huge to resetting some of these cycles.
Okay. How can people get the kind of ultrasound that, like, is an average ultrasound able to give the information to help people understand if they have one of these compression syndromes? Or does the ultrasound tech and the person interpreting it have to have some special training?
I would go with the latter. And the reason
Okay.
is this, even though these syndromes are described, you really have to have a tech who knows what they're looking for. Any ultrasound tech can take the probe and do the study. But what I realized was as we were going on this little journey, the techs weren't spending enough time or they weren't um, like in the right location because it's not built into the standard protocols. Most of what
Right.
and the way hospitals function, they're very protocol based to ensure good quality. And to their own fault, there's not a lot of room for creativity. And this falls into an area where you'd really have to prep somebody and say, listen, we are specifically looking for X, Y,
Mhm.
and Z. And because we're looking for X, Y, and Z, we need to look at X, Y, and Z and
Add
follow.
it to the protocol.
Yeah, not that it couldn't be done, but I think it would take
Yeah.
education. So my goal is hopefully we can get enough data that we can develop a really good protocol for this and then try to at least share it with other centers who'd be interested around the country.
That sounds great. Um, I think that's, and I'm just kind of looking at my last questions here. Oh, how do people get to you? Do you take people from out of state, out of country? Say someone's just like, this is what I
Yeah,
have. I just want to cut to the chase and go see
sure.
you. Yeah.
So we're easy to find. So there's only one private vascular surgery group in the city of St. Louis in the United States, in the state of Missouri, right?
Wow.
So I also have a terrible last name for a surgeon. It's Hacker. So if you were to go online and Google Dr. Robert Hacker, St. Louis, Missouri, you'll find the St. Louis Vascular Surgical Specialist. That's our specialty. Uh,
Okay.
you can email us information. You can call the office to set up appointments. We've been trying to. There's a lot of rules about treating patients over state with telehealth and what
Right.
license you have. So we have to be very cognizant of these things. There's many people who will just help guide them if they want to stay local. But if they wanted to come into town, we have very affordable fees. Unlike the big hospital systems, we are completely um, open to all kinds of pathways of meeting people and financing things where larger hospital systems are unable to do such. So
And like, I'm in Canada, as you may know. So what about taking people from out of country?
yeah, so the out of country, of course, a Canadian can come to the US, right? I don't even know how I'd practice medicine in Canada. But, one of the things we try to do as an added is instead of someone getting on a plane or driving all the hours down to see us, we would try to maybe have a non-diagnostic medical phone call, maybe for 30 minutes or,
Mm,
where we could do some pre-screening questions, to see whether or not this is something that we should follow or
right.
path we should go down so that we're not wasting time. Or patients' money or resources,
Yeah.
right? But it's been my observation that many of the patients with the dysautonomias, they know what they've got, they know how long they've got it. They have all the other studies that say what they don't have, right?
Right.
So usually they're coming to our clinic or approaching us pretty well prepared for a discussion. And
And
if
maybe a final question. What do you want people to take away from this? Say just the average listener. What's your message?
you know what I've learned, the biggest lesson is this: I didn't realize how many people, mostly women, are suffering. And what a gap in medical education, medical knowledge, diagnostic knowledge, all of this. And so I think I'd want to end on a very positive note that, you're not crazy. You shouldn't be dismissed. There are many causes that doctors are thinking about for many reasons, but a lot of them, and the way that many doctors think, I'm sure even in Canada, because there's similar training platforms,
Mhm.
they're very algorithmic. And if they didn't make it into a chapter, or they aren't a thing of interest, you're being dismissed, right? And so the doctors are using a lot of the tools to the best of their ability, right? GI guys are using endoscopies and biopsies, but these are coming up negative. The neurologists are doing their tests that we talked about, and they're coming up negative. You know, here's one more thread that you could pull, that you could explore. And we've been finding that usually this is the thread that needed to get pulled and needed to get explored. And we've been able to tie it all into one big unifying theory. And so I would say, don't give up, don't get tired, don't get frustrated. Just know you haven't found the right doctor yet. And maybe it's us, or maybe we can help you find that person.
Thank you so much. This has been very illuminating. I've learned a ton, and I'm pretty sure, the listeners will have as well. Thank you so much.
I appreciate the honor and the pleasure to talk with everybody.
Okay, bye-bye.
Thanks for joining me on the Dr. Eleanor Stein podcast. I hope you are taking away new strategies and ideas to improve your health and a renewed sense of hope. Join me, Dr. Eleanor Stein, for our next episode. Can't wait? Check out my website for a wealth of free resources.